Thank you for joining us. My name is Audrey Hassan, patient liaison for the MDS Foundation, and I'll be moderating the presentation today. As we get started, I would like to thank Acceleron, Bristol Myers Squibb, Jazz, Novartis, and Takeda for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation via our virtual Zoom platform. Today's presenter is Dr. Jean Ridgeway, a doctor of nursing practice and assistant scientific director in hematology oncology at AbbVie Pharmaceuticals. At AbbVie, she leads medical education activities for myeloid malignancies, including acute myeloid leukemia and myelodysplastic syndromes. There, she assists in the development and design of clinical trial protocols and also performs research studies to support therapy use and optimal patient management. She also has extensive experience, having spent many years treating patients with MDS and AML in the Department of Medicine section of Hematology Oncology at the University of Chicago. She is also a member of the MDS Foundation's International Nurse Leadership Board and has been the author or co-author of numerous publications on MDS and AML. So with that said, it is my pleasure to introduce Dr. Ridgeway.
Good morning. My name is Jean Ridgeway, and I am a member of the International Nursing Leadership Board, and I'm here today to talk to you about becoming a partner in your care. And this slide deck is called The Building Blocks of Hope. And it was designed especially for patients and caregivers with myelodysplastic syndrome. And it's geared towards an audience that is acceptable for newly diagnosed MDS patients and families, or patients who have been along in the journey for a while. So I'm going to advance the slide. And I just want to say, on behalf of the MDS Foundation, we're really glad that you're here today and you're choosing to learn more about what it's like to live with MDS. Because education can empower you. You realize the more I understand this disease, the better I can deal with it. Excuse me. And so we're here to help you begin to understand more, not only about the disease itself, but how you can take control of the situation and how you can learn the questions to ask as you learn to live with your MDS. So what can you do? It's not uncommon when people get thrown into the diagnosis that they never wanted and would like to give away. They feel very powerless and overwhelmed. I think it's very similar to going to a foreign country where you don't know the language, you don't have an interpreter, you don't have a map or a guide, and you really don't have a destination. So you're there very confused and overwhelmed. And our goal today is to give you some practical tools so that you can understand where the journey is going, that you can understand what your healthcare provider is talking with you about, and that you can understand what your options are, and you can understand how you can really empower yourself and your family to understand exactly what to do next. So first of all, what can you do? You can do quite a bit. I would very much encourage you to be active in this process. At times it can be a bit intimidating. If you're not in healthcare, if your life has been something totally different, this is a new language and a whole new environment. So you have a lot to learn. But I would say, most of all, be your own advocate and take an active role. If this seems overwhelming to you, then perhaps someone in your family can advocate on your behalf until you feel emotionally strong enough to be your own advocate. It could be your child, it could be your partner, it could be perhaps even a good family friend or some other person in your life. But be your advocate and take a role. Do feel empowered. You have a lot of options, even though you may not feel like it at this point in time, but you do. And questions, ask questions. You're seeing a healthcare professional whose expertise is in the management of rare blood diseases. And so they've gone to school for quite some time and studied many hours and gone to many conferences with colleagues so that they really do know the answers. So please feel free to ask questions and have open, honest discussions with your healthcare team. When you come and see your healthcare provider, ask questions that you're seeking an honest response to. Tell them with honesty what your symptoms are. If you're too tired to get out of bed or you're needing to nap more than, say, an hour or two a day, if things are really changing with your healthcare team and with your health, let your healthcare provider know about it. Otherwise, they can't help you to the best of their ability. So nothing you can say is going to startle them, is going to overwhelm them. If they have an answer for you, they'll give you an answer. If they don't have an answer, they'll explore options and get to the bottom of your question. But in order to do that, on that two-way street and navigating it, you need to have, on the onset, being honest. Make your wishes clear. Know what you want and what you don't want. And make sure your family is aware, or your extended network, of what you want and what you don't want, because they'll be happy to carry out what you would like. You just need to communicate with them what you do want. And I would say, most of all, prepare for each visit with your healthcare provider, and we'll go through a little bit more what that can look like. And to the best of your ability, in all other areas of your life, stay well. We'll talk about some key strategies to do that. So how can you make the most out of every office visit? So if you're like most people, going to the doctors have been intimidating. And now in this era of COVID, it's very different. Perhaps you won't have a live visit. You may have a virtual visit. But many of these pointers also apply to a virtual visit. Before the visit happens, ask yourself, what do I want to get out of this visit? And write down the top 3 things you want to discuss. Now, this means that you have to have some type of recording device. Many people like to just get a plain notebook or some type of pad of paper that they can keep notes on. I'm an old-fashioned type of person. I like writing things down, and so I would be someone to keep a notebook and have my questions written down. That way, when you go, you've already prepared ahead of time of what you want to discuss, and you've taken the time at home to write them down. It's very easy to forget things if it is a live visit in the hustle and bustle of getting to the clinic and all it takes to get there, to forget what you want to speak about. So write them down and pull that notebook out. I always found it so very helpful when patients or their families and caregivers would write things down, because we knew exactly what we wanted to discuss, and then they could get answers and feel more in control of the situation. And focusing on this agenda is going to help you make the most of your time. Visits are time limited, right? And although we would all like to spend a lot of time chatting with the healthcare provider, the truth is that visits are crunched for time. And so in order to be the most efficient, set an agenda and be efficient yourself. So that list of questions, list that questions in priority order. It might be something like, what are the results of my CBC today? What's my hemoglobin? Do I need a transfusion? Could we instead do transfusions closer to home? How often am I going to need transfusions? Is there anything else we could do? So a list of questions is is very, very helpful in how you want to prioritize them. In case one question consumes the entire visit, you'll at least have taken care of the most important to you and your family. So start with this list and bring it with. And I would say always bring someone with you to your visit if it's a live visit. What we used to do in our clinic, if perhaps a family member had a conflict and they couldn't come, we would FaceTime them in, or we would do an audio call. But having an extra pair of ears to hear, if you're simply listening to the healthcare provider, which is totally fine, someone else can be taking the notes and perhaps doing a little bit of digesting of the information. So bring a person of your support team with you, and do ask them, say, would you be willing to take the notes while I ask the questions? Some people do this electronically. They bring an iPad or they bring some type of smartphone and they use the note section. So that's another option to do as well. So lots of options to get the information and have it written down. That way, when other family members call and they say, oh, how did the doctor visit go today? Instead of saying, oh, fine, you can say, well, we talked about these 3 things and XYZ, so that you can be very specific with sharing of your information. So I hope that's helpful to you. You also want to bring any information to the healthcare team. So the person you see for your MDS may not be the person that you see for your general medical care. In the majority of cases, you're seeing some type of blood specialist. So they aren't managing your diabetes or your COPD or your prostate cancer. So what you need to do is update them on anything new that has changed from your last visit. This may be something like a prescription. If, in this day of smartphones, take a picture of your new prescription bottle. It's hard to remember those names and what it's for, but if you take a picture of it or bring all your prescriptions with, then you can update them, because it's very important that your MDS healthcare provider knows exactly what you're taking. Let them know about over-the-counter medicines. Have you suddenly developed a resurgence of low back pain and you're taking some type of over-the-counter medicine? What about vitamins? What about herbal medicines or homeopathic medicines? So many times herbals or homeopathics can initially, we think they could be helpful, but sometimes they can be harmful. So do bring those medicines in and share that with your health team. Again, circling back to that, be honest with your healthcare so that they can know exactly what they're taking. Make notes on your symptoms and any side effects that you're having. We're going to talk about an app that's available from the MDS Foundation that you can use. And part of it is a symptom tracker. So you can use the symptom tracker in the app to help you record your different symptoms. If you've had any tests from other healthcare professionals that you may be seeing, bring them with. Remember, your healthcare is your property, so you can always ask for a copy of a report. Even something simple as going to the dentist can be more complicated for someone with MDS if your platelets are low or your neutrophils are low. So make sure all that information is being shared. Another option is if your physician office has access to electronic medical records, many do, but not all, they can request electronic permission from the other health systems so that they can get those notes directly. That will involve the requesting healthcare professional, so your MDS doctor, to have you sign a consent that allows him or her to see, say, your cardiologist reports. And then anything else like transfusion records. So if you are coming to see an MDS specialist, say at a large center, but it's not where you usually go, they're going to ask you questions about, are you receiving transfusions? If so, when? So again, recording and keeping record of your healthcare. So you can do something as simple as just keeping a list. I've had patients who were very savvy with computer programs. They keep an Excel spreadsheet. Some people copy calendars, and they'll make notations of when they have blood drawn and when they receive transfusions. So again, keeping lines of communication open and allowing your MDS doctor to know exactly what's going on with all of you. And when you are leaving the doctor's office, you should leave, the goal would be with a clear understanding of the plan. When's my next appointment? Are those follow-up appointments made? I think making an appointment, even if you have to change the date or time, is a better solution to follow up than saying, oh, I'm going to call, right? Because that can be very cumbersome to get through the different layers of voicemail to get a follow-up appointment. And do you know what the treatment plan is? Your treatment plan may be, I will see you in a month. We will recheck your blood counts at that time and discuss next steps. Your treatment plan might be, we will start a first cycle of therapy on this day, etc. So it can look very, very different for many people. If you're given a prescription, make sure you are clear about this new medicine, right? What is it? What's it for? How am I supposed to take it? How am I going to get refills? If it's a new medicine, sometimes doctors only write for 1 month. They want to see how you're tolerating it. Others will write for additional refills. Many people have prescription plans where they can fill their prescriptions on an every 3-month basis, which requires a paper prescription and some mailing in of documents. So make sure that all gets taken care of, or at least you can have a contact person circling back to get that done. If you need a referral to other providers, some patients have managed healthcare or an HMO, and perhaps seeing the blood doctor is a referral. So getting the referral from the primary care doctor, or perhaps your MDS doctor is concerned and wants you to see maybe a gastroenterologist, a GI doctor. Get those referrals and perhaps names, right, to other providers. Listen carefully to the instructions and ask for clarity. So you may want to, the doctor says, remember to wash your hands frequently. If you have grandchildren, you may want to stay clear. We're going into flu season. So make sure that you're clear on what you can do and what you can't do. If you have a graduation coming up or a wedding, can you go? Can't you go? Are there limitations? What are any guardrails to keep you safe? And then what about symptoms or problems that need to be reported to the doctor? When do you call the doctor? Who to call, where to go, and how to do it? And so leave there with a solid plan. You can ask the doctor in the office for a card. Many times, patients who have blood cancer are triaged in the healthcare system differently than someone who has a healthy immune system. So make sure you're clear on who do you call and where do you go. And especially with MDS, if you're developing a fever and you're really feeling quite unwell, even if it's late in the evening or the weekend, do call your doctor and say, or, perhaps your family or caregivers are going to have to call and say, Mr. Smith, that's just a hypothetical name, he's your patient and this is what's going on. And then, the doctor may say, come and see me in the morning or go straight to the emergency room. So make sure that you're clear on what you need to do and how you call, who to call, and how you manage that whole system. So what can you do, switching gears here, what can you do to stay healthy? Well, I think you can do quite a bit. Certainly the MDS piece is managed, but what about the rest of you? So, you're living, you should enjoy life and enjoy the things you love to do, right? If you're needing help with something, say perhaps you need help cutting the grass, or as winter is approaching here in the Midwest, what do you need to do to winterize your house? So make sure that you ask for help as well. Leading a healthy lifestyle, we'll talk a bit more about that, and then learning to manage and report your symptoms, and then being an active participant in building hope. So let's talk a little bit more about each of these. So what about lifestyle? So lifestyle can play an important role in your overall physical and mental health. You want to lessen or manage the side effects of treatment. No matter what treatment you receive, it always has side effects, right? Even receiving a blood or a platelet transfusion, right? The side effect of navigating, having to get to the clinic, getting the type and screen drawn, sitting there for many hours, etc. So, learning how to manage that. If that means I need to wear really comfortable clothes when I come to the clinic and make sure that I get a bed, that's fine. The staff will work on you with that. If you're receiving a treatment, say an injection that's causing skin irritation or itchiness, that as well. Or some therapies may cause a little bit of GI upset, be it, a little nausea or diarrhea and constipation. Pointing those out and having that discussion with your care team so that they can give you suggestions on how to lessen that impact of side effects on your treatment. You want to keep your immune system strong to aid in the fight against MDS or other illnesses. And part of that is diet, washing your hands, keeping active by walking is also very helpful. Unfortunately, contrary to popular myths, there's no magic pill that you can take to quote unquote boost your immune system. There are no fad diets. There's no, unfortunately, magic wand to help you do this. But good balanced nutrition, and we'll talk about that a little bit more, can help you holistically, just to help that immune system, right? So you want to eat a balanced diet. And you want to improve your emotional outlook throughout the diagnosis and treatments, right? And you want to decrease the risk of other medical problems, right? So, for example, I would say if you're smoking, consider joining a smoking cessation solution. That can look a lot of different ways. So decreasing that medical problem. And fitness. So for many people, fitness, depending on your life stage, looks remarkably different. If you're in your 30s or in your 80s, fitness can look very, very different. So, but walking is part of fitness, and keeping to an active lifestyle is certainly important. And we'll talk more about that. Let's go back and talk about nutrition. How do you keep that balance and perspective? Some general nutritional guidelines. I'm not a nutritionist, but these are very general guidelines. And you want to stay hydrated, right? And so hydration is best done by drinking water, right? Now, depending on your water source, you want to make sure it's safe. Some people have well water. Having your well water tested to make sure that it's safe is a good thing. Bottled water is great. There's a number of filtration systems, but basically you want to stay hydrated. Hydration looks at if you have a healthy heart, so you don't have heart failure and you're not on a fluid restricted regimen, drinking about 2 liters a day of anything that counts as a fluid. So things that count would be water, juice, anything with caffeine in it only counts for 50% because caffeine is a bit of a diuretic. So you want to be drinking that. How do you do that if people really aren't big water drinkers? Sometimes people start out with getting a pitcher and keeping it out, and they know when the pitcher is empty, say it has 1.5 liters in it from the day, then they've done their part in staying hydrated. Keeping a water bottle, I always have a refillable water bottle with me. It has 750 milliliters. That's the volume of it. So I try to drink 3 to 4 of those a day. So diet. Balance is really the key. And I think a good rule of thumb is if the food is as close to a natural state, it's probably the most healthiest. So what do I mean by that? Eating fruits and vegetables. So broccoli is broccoli, a banana is a banana. You can eat fruit and vegetables. Those are totally fine. Some people worry about if they're neutropenic, what about restrictions? And there's been a lot of changes through the years. If it grows in the ground, like a potato or a carrot, wash it well, right? You're going to peel it, so that's fine. So the only restriction you have to be careful of is fresh blueberries or raspberries, since they can get moldy. You can't really clean them well, so those you should probably stay away from unless they're frozen and blended. That would be okay. Meat should be cooked, so no sushi per se if you're neutropenic. There lately has been more concerned about lunch meats, so kind of staying away from that. And if you have specific questions, talk to your doctor about it, right? But trying to stay away from highly processed foods is a good way to get balanced nutrition. You want to limit alcohol intake or exclude. If someone tells me they have 1 drink a day, I always say, how big is the glass, right? That's important to know. What about calories and protein? Depending on your gender, your activity level, and your age, we all need different amounts of calories and how much protein. So protein you can get from meat sources, eggs, fish. If you're a vegetarian, you can do that through legumes or different types of beans. And again, avoid the fad diets and do ask about supplements. Most of our food is perfectly fortified. Is a multivitamin going to hurt you? No. Is it going to help you? If you're eating a balanced diet, some people say there's not a lot of benefits. So talk that question over with your physician, bring in your bottles and talk about that. And be sure to understand if you have food restrictions, what exactly they are. So what about exercise and fatigue? So believe it or not, the single most important way to combat fatigue is by being active. I would often have patients refer to a physical therapist to develop some type of tailored program. And you can ask your doctor for that prescription. Most insurance companies will cover it. It could be for balance and gait. Gait's another word for walking. So they can assess where you are, and they're trained. So I feel a little more comfortable about sending patients to a physical therapist over a quote unquote trainer to develop some type of strength or training program. So you can use resistance bands. Those can be purchased online. You can get them from various sources. But having some type of structured 30 to 45 minutes 5 days a week is great. Even walking is great, right? I always used to have a saying and ask my patients. It was called the target test, like how far could they walk in Target, right? So you want to be able to walk around quite a bit. So cardio walking is great. Walking's free. You can do it anywhere. If you live very rural, roads are bad or whatever, you can always walk in your home, right? You can walk on the roads. People who live in more urban areas could perhaps go to malls. I don't know if the malls are open to allow for mall walkers. There are a number of communities that have something called silver sneakers for folks who are older, and often at a reduced cost. So other things to help manage that fatigue is getting enough rest, right? So if you're having trouble sleeping, talk to your physician about is there anything that you could try, and developing good sleep habits. We'll talk about that some more. In that, if you're going to have something to eat before you go to bed, make it kind of light, right? And recently, there's been a better understanding of if you read while you're in bed. A lot of people read with some type of computer device, like a Kindle or maybe even on their phone. You want to use the backlit. You want to use the darker setting because our eyes and our brain get activated with the light source from the computers. Your sleeping area should be relatively quiet and comfortable, and then help your body relax. There's a number of apps that are available to help you relax as well. There's one a lot of patients enjoy. It's called Calm, C-A-L-M. It's free. So that's another option to help your body relax. So what about tracking your blood counts and taking control? So let's talk about anemia. So what is anemia? Some of you know this very well, but perhaps some others don't. So anemia simply means that you have too few red blood cells. And red cells are really important. This little diagram on the upper right side of the slide, they're biconcave, right? So they're concave on each side, is a red cell. And their job is to carry oxygen to everywhere in our body, right? The most common blood disorder with patients who have MDS is anemia. More than 85-90% of all MDS patients have some level of anemia, okay? Now, when your body doesn't get enough oxygen, you have symptoms that go along with that. You're tired, right? You could be short of breath, right? Your lungs are having to work harder there's not as many red cells, so they can't exchange the oxygen. So you can be short of breath, even with walking a short distance. You may have a headache, so your brain's not getting enough oxygen, or perhaps you feel like your heart is racing. Some people talk about hearing the swooshing noise in their ears when they're profoundly anemic. So anemia is measured as hemoglobin or hematocrit, and there are different normal ranges for males and females. So you can see that the male range is higher, 14 to 18 grams per deciliter versus 12 to 16 grams per deciliter for females. And hematocrit is simply a ratio of that. So it's a 3-to-1 ratio. So when we look at anemia, people think right away, well, what about a transfusion? How come my doctor's not giving me a transfusion? So there are recommended medical thresholds for when you receive a red blood cell infusion, and that usually is at about 7 grams per deciliter or 8 grams per deciliter. Your doctor's going to, do that for you and understand where you tolerate and when you need a transfusion, right? And the problem with MDS is that your bone marrow is just not making enough of the red blood cells. So yes, you can get a red cell infusion, and that does treat the symptoms. It doesn't treat the cause. So that's just a little bit more about anemia. Now, if you haven't taken a tour of the MDS Foundation website, there's a lot of great resources that even further describe anemia as well. And this is the MDS tracker. So if you download this on your phone, it's a free app. So let's talk a little bit more about blood counts. What about something called neutropenia? What does that mean? So neutropenia means you have too few neutrophils, which are a type of white blood cells. And what having low white cells does is that it increases the risk of different infections, especially bacterial infections. So that means on the skin, so a cellulitis, sinuses, or lungs, meaning, like a pneumonia, urinary infections. And what are the symptoms? Fever is the most common symptom when people have an infection. Certainly you can have a cough if you have some type of respiratory infection. And then overall, people feel generally weak or they just don't feel well. Well, let's look at a normal white blood cell. And just as a way of giving this a higher level overview, when you get your blood count done at the doctor for MDS, we're really looking at that CBC, the complete blood count. So it checks the whites, and then it will list the type of white blood cells, checks your hemoglobin and hematocrit and some other indices of your red blood cells, and then your platelets. So this, we're talking about the white blood cells. So you can see here on this slide, it talks about the total white blood cell and what the normal is, and then the different components. So the neutrophils are the largest component of the white blood cells. And then we have other members of the white blood cell family. And what you'll hear often is the doctor will talk about what is your absolute neutrophil count, or if you take the first letter with each of those words, the ANC. And to get the ANC, usually our laboratory computer does it for us, but if you wanted to do it manually, you would take the total number of white blood cells times the percentage of neutrophils, and then you would come up with an ANC, or an absolute neutrophil count. So it's always a percentage of the white blood cell count. What about platelets? When platelets are low, we say that you have something called thrombocytopenia. So platelets are another component of our blood. They are a normal component of it, and the normal level is we have about 150 to 400,000 mm's per meter cubed. And what happens if they're low? So since their job is to help prevent bleeding, when they're low, what we do see is we see easy bruising, we can see prolonged bleeding. So say, for example, if you cut yourself in the kitchen, you would see that the scratch bled a lot longer. Or if you go to the dentist and you have a tooth extract, you may have a bleeding problem from that. And that could be relatively severe. Sometimes, so there are a number of different bleeding occurrences from mild to severe, just to let you know. Now, the risk of spontaneous bleeding, so here's your normal, 150, 400,000, but the risk of spontaneous bleeding doesn't happen until patients' platelets count is under 5,000. So there's a wide spread of safety, and there are other metabolic processes to keep you safe as well that your body has in place. So getting back to what can you do to stay healthy and avoid infections. So usually patients are having their blood counts checked on a fairly regular basis. If you're a newly diagnosed MDS patient, the doctor may have you come back pretty frequently the first couple of weeks to understand exactly what your bone marrow is doing in producing your blood cells. So you may have to come in every week for about 8 weeks. Or if you're starting treatment, many times patients will come in then once, sometimes twice a week to get their blood counts checked. So knowing what your blood counts are and it's very helpful, and the only way to really know them is to get your counts checked. Obviously, if people who are ill, so having visitors is great, but if they're not feeling great, they should not come over. Washing hands, we now all live in an environment where I think we're perhaps better about washing our hands pretty frequently, right? So washing your hands with soap and water is the best thing to do. If you don't have that available, using one of the waterless options is also a great option. And again, understand exactly when you need to get a medical attention. So I would suggest that you get a thermometer. There are lots of different types out there. Get one that's reliable, because the doctor will probably say, what is your temperature? So you need to have some way of measuring that. All right, what else can you do? Immunizations. You need to get a flu shot, and so does everybody in your care team, right? I got mine last week, and it is not a live virus, and so it is perfectly safe to get, and it is one that you get every year. So get your flu shot. Years ago, people would say, oh, I get sick from the flu shot, and that had more to do with the constitutional creation of the flu shots. Now, they no longer are manufactured that way, so people don't get flu-like symptoms after they get the flu shot. What about the pneumonia vaccine? Well, there are two different pneumonia vaccines out there. One is called a Prevnar, or a PCV13, and the other is called the Pneumovax, right? So being up to date with when you last received the pneumococcal is very, very important. So again, the risk of getting pneumonia is far greater than the risk of getting the pneumonia vaccine. So make sure that you're up to date on your pneumonia vaccine, as well as your caregiver as well. Now, there are a couple different formulations of the quote-unquote shingles vaccine that are recommended. There's a certain type that has a quote-unquote dead virus, so make sure if you're going to the primary care doctor, if you're over the age of 65, that you're letting them know that you have MDS, so that they can recommend the correct form of the zoster vaccine for you. How about bleeding, right? So you do have an increased risk if the platelets are under 50. So what you want to do, again, is record and track them. And then most importantly, we talked previously about what type of medications were you on, both over-the-counter and prescribed. But if you're taking any type of blood thinner, say Coumadin or warfarin, which is commonly prescribed for patients who have atrial fibrillation, and your platelets are under 50, that more than likely is going to need to be held, or Plavix. So make sure, again, you're letting your doctor know all the medicines. And some of the herbals and homeopathics can also increase your risk. So again, being transparent about what you really are taking. And of course, this is kind of silly, but doing our best to avoid falls and injuries as well. So some good household tips, getting rid of perhaps like throw rugs, being careful about extension cords, etc., to help you stay safe at home. We talked a bit about this, managing comorbidities. Comorbidities is a fancy way of saying other health issues. So stay connected with your primary care doctor and all of your other specialists. Your MDS doctor will manage your MDS, but they will not manage your heart failure, your diabetes, etc. So I know many people are like, well, I'm already at this doctor. Can't you do X, Y, or Z? But, it's necessary for specialists to see specialists. And so I would say staying connected with all those other people as well. And again, your doctor may say, oh, tell me your cardiologist's name. I'm not familiar with him. So if you could come ready with that information, phone numbers, emails in this day and age as well, so that they can collaborate with one another and have the very best plan for you. What about participating in a clinical trial? Some of you may have previously or are currently participating in a clinical trial. And some of you may not, or you may be relatively new to this area, so you don't understand what a clinical trial is, know that all of our current treatments for myelodysplastic syndrome have been developed through clinical trials. So clinical trials may offer you access to treatments before they're approved and available from through the FDA, and ask your doctor about are there any clinical trials that might be available to you. If you go to the MDS Foundation homepage, you will see that there are many current clinical trials that are listed that you could have access to. It does require work on your part or your care team or your support staff to really look into that. So there are a number of MDS trials that are occurring across the United States, really across the globe. However, they often require that you go to that center to participate in it. So geography could be a limiting factor in that, but there are great options and another option in your care. And this is the homepage of the MDS Foundation. If you drop down to on the blue bar, there's many options. So there are resources in understanding what MDS is. There's a section for healthcare providers, for visitors, for patients, etc. So all these resources are available and they're free. What's required from you is to visit the site and click on the area that you are most interested in. So obviously, if you're listening to this, you have had a touch point at least with the MDS Foundation. But I would encourage you to take full advantage of everything that they do offer. These slides are available for free. You can download them under the Building Blocks of Hope. There are message boards. You can see there is a link for the MDS app. There's the Bone Marrow Handbook. There was a book that was published and updated pretty recently, and it's called 100 Questions and Answers about MDS. It's a great little book. It's online, or they'll send it to you. So if you're not techie savvy, you can call or write the MDS Foundation as well. So I would say by far one of the best resources, if not the best resource, for you understanding MDS. And there's quick tips both on the Foundation webpage or if you want something on the MDS Manager. So all different things, something, anything you can think about is that. There is a video series called You and MDS, which is available as well. There are some learning modules, and then there are also patient stories where you can hear firsthand experience from patients who are living with MDS. So, MDS is a rare disease, and oftentimes people can feel overwhelmed. The doctor may say, "Oh, you're my only MDS patient," or "I only have 2 or 3 of them." So feeling isolated and where are the rest of these people? I think this would really encourage you to be able to understand from other people's perspectives, how are they dealing with MDS? So again, free, you can watch it. It's a resource designed for you and your caregivers in mind. And then again, here's the MDS app. So it can go on both an Apple or an Android smartphone, or it could go on a tablet. And the key features, again, we didn't really talk about it today during this presentation, but if you want to know your IPSS-R score, we can talk about that later when we have interactive section. The symptoms, you can download. So it's got a lot of different key features. And then you also have the opportunity to participate in a virtual support network. And you can get interactive support through the MDS Foundation. And you can use whatever you would like. You can use as many or as few of the MDS managers that meets your need, or your family could. And then the MDS Foundation has an app as well that you can, again, it's free, it's available in Google Play and iTunes. And one of the services that's involved, that is given here, is that if you would like to locate an MDS Center of Excellence, you can use this app to do so. So there are a number of centers across the globe that the MDS Foundation has identified because of key thought leaders and key practice physicians in MDS. So if you're looking for a second opinion, using this source to find an MDS Center of Excellence that geographically is convenient for you as well. And then it's another way to look at patient forum and patient events that are going on and other online resources as well. So something else to help you empower you with your. And then there is an MDS outreach and advocacy program. So our patient liaison, Audrey Hassan, you can call her or you can email her to talk to her about different aspects of MDS and get lots of information. She's a wealth of information and happy to help you with your questions. So I just want to say thank you for giving me this opportunity to go over this material with you. It's a lot. There is an electronic survey if you want to take a look at, or a paper survey as well. So thank you again very much and enjoy the rest of your day.
Before we get the first question, I just want to say thank you for taking time out of your day to join us, and welcome to my Zoom room in my virtual background, which is hiding my basement. So I guess I had, if people want to think about a couple of questions, one of my questions to kind of understand the audience, if I look at this correctly, there's over 50 people on the call. So to try to get a gauge of where you are in your journey with MDS, my question would be, and you could chat it to everyone and I can read the answer. I would imagine that there are a number of patients who are relatively newly diagnosed. So if you've been diagnosed just a few weeks or months, maybe you can just chat in, say, "Oh, this is new to me. We've had patients come to the live discussions who are literally days or the first week after hearing about their diagnosis. And there are some people who have been living with this for a while, maybe at least a year. Someone said since July 2020, 3 months. There are other people who have had a stem cell transplant and are, so thank you. So someone lost their partner about a month ago. I'm sorry about that. 5 years, 8 months. So July 2019, a little over a year, 11 years. There you go. Congratulations. And the other thing that's kind of exciting with Zoom is nobody has a mask on. We all wear masks so often. It's like, oh, look, there's real people. So fun. 2 years, August 2018. So, you're all in different spots about what kind of questions you have. But I guess, one of my big questions to all of you to consider is, what concerns do you have that we could help you through today, that we could begin to uncover some of the answers for you? Almost 2 years, 5 weeks, brand new, 3 years post-transplant. Congratulations.
Jean, we have a question from Jerry.
Uh-huh. All right, Jerry, I'm all ears.
I think we're waiting to unmute him. Our facilitator will unmute Jerry.
Okay, there we go. I
Very,
had sent it in as a text. I have severe cold agglutinin disease, and that requires that my sample be placed in a heat block.
mm-hmm.
Sometimes it's in the block for half an hour, sometimes 45 minutes, sometimes 20 minutes. My question is, the sample being in the heat block for that long, what effect does that have on the accuracy of the sample?
Jerry, good question. So for everybody else on the call, Jerry's telling us about he has an issue with his blood. So when they draw the blood and they want to look at the CBC, what are the effects of it sitting to get warm, right? And so like with the processing, and honestly, I would need to do some research for you. So I would say if you could circle back, I will do my best and talk to my friends in transfusion medicine to get an answer. Do you mind? What do you know so far? Has your doctor said it has an impact? It doesn't have an impact?
My doctor has said that it does not have an impact, but my sense was in his discussion with me, he was just putting me off. Because there is no alternative. My blood
Right.
has, I live in Southeast Florida, and I go to one of the best facilities in the area, Boca Raton Regional Hospital. It has a separate hematology and cancer institute in a separate building. So I have to go to the main lab, have my blood drawn because they have to run it into process immediately. And then I go over to the Cancer Institute and see my doctor.
Mm-hmm.
So my sense is that, it's almost an emergency. So my sense is that it's very fragile. And if it is so fragile, why are they warming my blood for such a long time?
Right. Honestly, I have to.
They're not boiling it.
Yeah,
I know.
Yeah, there are people who have a lot of antibodies in it, that the blood needs special processing, and so it's one of a few different types of unusual occurrences that commingle with the MDS that needs special processing. I think the best thing to hear is that you go to a large center, so they have the resources and the expertise. But let me, Audrey, later we can exchange emails, and then I'm happy to look into that further for you if you'd like. But I can't give you a great answer right now because I'm limited in what I honestly know about that.
Well, I really would appreciate that because I'm at this for 6 years now. And that question has been in my mind as my cold agglutinin disease has gotten worse and worse and worse. And he's even warned me that if I go up north in the winter, that I should take really good gloves and a really good hat and wear my shoes and socks all the time.
Yes, that's very true. For our patients here in the north that have cold agglutinins, the cold is difficult. So it's good to hear you're someplace warm.
Thank you, Jean. There's a question from Joseph, and I just happened to speak to Joseph, so I recognize you, Joseph. Thank you for joining us. He's newly diagnosed.
Yeah, I thought you were going to read it, Audrey. That's fine. My doctor uses Navigating Care, which is the cancer company's patient interface.
Okay.
It's an awful interface. It's you get email notifications that there's something there. You have to search around for it. The hot links to Medline are also minimalist, not a lot of good information. Do y'all have experience using a patient interface online with your physician that isn't Navigating Care that you feel comfortable with? Because I'd like to see them move to something that's a little more user-friendly and detailed.
Yeah, Joseph, that's a great question. There's, all types of electronic medical records out there. None of them are perfect. My experience, what we were using at the university, we were, as a university, a little bit slower to interface with this. I live in Chicago, and so there are other areas that in the city that use different patient portals for gaining that information. I know that they're exceptionally expensive for organizations to buy, right, and to implement, and it's. I mean, you can ask them about, like, are there any improvements? I think it would be helpful for them to hear, like, just as feedback for somebody to understand what exactly the difficulties are. But I mean, I would open it up to some of the other people on this call.
I don't want to steal any more time. If folks send me a chat note, just send me a note private to Joseph, and let me know the brand name of your online service. And
okay,
we'll move on to the next question. Thank you.
All right. Epic is a big electronic medical record, and so Epic has some type of server associated with it. To stay within the system and get those questions and answers. That's just another example. There are many, many others.
Thank you, Jean. We have a question from Net. I see Net up there. Hi, Net. Your question is, we'll have to unmute you. Perhaps just in the interest of time, I could read your question, Net. She's been told there's an age cutoff on getting a bone marrow transplant. Is this true?
The age of stem cell transplants that are done for MDS are something called an allogeneic transplant, where you receive cells that are other than your own. So through the decades, that limit of age has continued to rise. There are centers in the country that if the patient has otherwise pretty decent health, transplants have been done up into the early 80s. I think last year there was probably a dozen to 15 patients who were over the age of 80 with MDS who got transplants. The center that I worked at, we actually had a specialty clinic for older patients, but there's a lot of parallel requirements when you look at transplant as well, because there are a couple folks who are on this Zoom who are folks who have lived the experience of transplant. So it is. It can be a very difficult recovery, so you have to be healthy enough to go through it. So is there quote unquote an age? If you go to some of the bigger centers who are doing transplants for patients who are in their upper 80s, that would be another option. But that's a complicated question. I haven't heard about anybody 90 yet, though. I have heard of folks in their 80s.
I have too, which is a good thing. So, Jean, the next question comes from Pat. I could read Pat's question. My husband has run out of options for treatment for his MDS, and he has been receiving blood and platelet transfusions weekly since June. I worry that the doctor at some point could decide not to transfuse anymore. Is that true?
Well, if transfusions are keeping your husband's symptoms under control, from what you say in your question, that then I would say no. The bigger question is, in talking with the doctor, in understanding just kind of like long range plans, what to do and what not to do is kind of the bigger question. And so transfusions are always, they're a supportive measure, right? They're not,
they're not treating the underlying problem, but they do support people. So I would say there's not a reason to stop, but you just ask him, right? Or her.
Mm-hmm. And then maybe also, if I could just add in, if he's not going to an MDS Center of Excellence, I'm happy to facilitate that. So I'll give my email address at the end of the presentation for anyone who wants to reach out to me directly. The next question is from Bob. Bob, are you there? Bob Lacone?
Hey, Odd, this is Tracy. I think everyone has to unmute themselves if they want to talk. I was speaking with Andriana and she can't individually unmute people. So when you call on them, they have to unmute themselves.
Okay. And to find the unmute button, depending on if you're on an Apple or just a PC, if you hover that arrow towards either the bottom or the top of your screen, and a screen will come up that shows like chat and mute and stop video. So
great, thank you, Jean. I'll read the question for Bob. He was diagnosed with MDS in 2007, now getting transfused every 2 weeks for a long time. Is it possible this could continue for many more years? I'm intermediate, but very stable. With my CBC tests, I feel very good until my hemoglobin gets low. He goes to Yale Smilo, which is an MDS Center of Excellence in New Haven, Connecticut, and he says he trusts his hematologist.
Right. I mean, it sounds, I think what I'm hearing you ask is like, how long can this continue, right? So, my answer to you would be as long as you continue to benefit, right? I'm not sure if your doctor has talked to you about something called iron chelation, right? Because every time you get a red blood cell transfusion, you do get infused iron. And there are some, since you've been getting them for a while, you may, your care team may want to consider that. And there's some oral formulations that you would take to help get your body get rid of that. So, the transfusions, again, they continue. So it sounds similar to our other question. Always being like, how long can this go on? Right. So the other piece of it, I would say it really is important to ensure that, you're in contact with your primary care doctor and that everything else besides your CBC is going well, right? Like, is your heart in good shape? How are your kidneys doing? Right. So, heart disease is far more common than MDS. So you want to make sure that you're also paying attention to your other health needs. So I hope that answered your question.
Thank you, Jean. That was a great answer. So keeping in line, I'm getting a message from someone. Anybody else on Aranesp? How long?
Mm-hmm. So for people who don't know, Aranesp and its cousin drug, something called epigen. So red blood cells are produced right in the bone marrow and in response to not only demand, but different hormones. And so epigen and Aranesp are a hormone that stimulate red blood cell production, right? And so how long can you be on it? You can be on it as long as it continues to benefit you. So some people benefit for quite a long time. And some people don't. So it all depends really on what's going on with your disease, because of all the folks who are here on this Zoom call, every situation is unique. So that needs to be teased out with your care team as well. But
thank you, Jean. Mm-hmm. I have a message from Neil, and he's saying that his EPO shops help him very much. He recently broke an elbow, and asked if an extra shot would aid the bone to heal. He's had MDS for 15 months.
Okay. Thanks, Neil. So EPO helps with red blood cell production. It doesn't help with your bones healing, unfortunately. So what's going to help your elbow to heal is, unfortunately, the thing that we all don't like to hear is just time, right? Time, and I don't know if you're just simply in a sling or if you've had to have some surgery. But as that bone recalcifies, bones take a while to heal. But unfortunately, the EPO won't make it heal any quicker.
Thank you, Jean. So, Kay, we'd like to hear from you virtually. If you're on, you can unmute yourself.
Yes, I have low risk MDS, diagnosed about a year ago. My doctor at Mayo is just going with the CBC counts to watch and wait. I, of course, feel tired most of the time, and I do have anemia with 10% ring sideroblasts in my red blood cells. I'm wondering whether I should inquire about transfusions, but I'm wondering what other kind of side effects the transfusions get other than the iron buildup. Are there other side effects that are dangerous or can give you other problems?
Yeah. Thanks, Kay. That's a great question. Again, you're also going to a great center of excellence. They have wonderful hematologist specialists up at Mayo. Ring sideroblasts is a special type of low-risk MDS. And I think the question perhaps needs to be, at what point would they consider transfusions? So watch and wait is perfectly appropriate. With MDS, the blood counts can, they get low to a point where you seek a doctor's opinion, like, why am I so tired? Or why do I have this shortness of breath? So you're at a point most likely that you feel short of breath and tired. So that would be going into the next appointment. I would say, when would they consider doing a transfusion? What are they looking for? And if you've had a change in that activity level, the target test, right? Like if you're going to Target, can you walk down an aisle, or you just can't, and you have to, or you just go a little ways, right? So how short of breath are you? Are you having any headaches, palpitations? Because, with low risk MDS, many times before the physicians start transfusions, they do these therapies, these EPO or darbepoetin, where the hormone stimulates the production of the red blood cells. So I would, you can say, what about the injections, right? To boost my red blood cell count, but to really ask them what is the threshold? Help you understand, so that if there is a change, you can call them.
Okay.
And then the second half of your question, what are the quote unquote risks to transfusions? I will say that, blood transfusions are far safer now than they were decades ago, right? So blood is screened very carefully for different viruses. When people do need a transfusion, and they first have to draw a sample called a type and screen, where they not only match you to an appropriate type, right, like A negative, B, O, whatever, but they look at, I think it's 269 different antigens on the red cell to ensure that the type of blood you receive is safe, right? Is there a risk? There's a small risk of acquiring some type of infection from the blood transfusion. But by far, the benefits far outweigh the risks. Receiving a blood transfusion requires for that type and screen to be done, and depending on where you're going, then it will always take an hour and a half to 2 hours for the type and screen to be complete, so that they can see if they have blood for you. And then it's what's their supply, right? So supply is kind of down in this area of COVID. The Red Cross and Life Source delivers blood to different centers. So depending on where you're going, they may or may not. You may get it the same day. You might have to come back the next day. Every place is different. Some people go to the outpatient setting. Some people have to be on a short stay unit. And so the side effect is time, right? It's kind of got to block off time and understand what is this going to look like if I do get a transfusion.
Thank you, Jean. That was very thorough. David, I know you're there. I saw you earlier. David Cushman has a question. David, you'll have to unmute yourself.
Yeah, I think I got it. Can you hear?
Yes.
Hi, Jean. Thank you for your time. Appreciate you doing this. I was wondering if you've had any experience yet with the newly approved FDA oral decitabine. I think it was approved back in July.
That's correct.
And I was wondering if you or anyone on the call has had any experience with that to date.
Yeah. So in the area of MDS, there's been a lot of development and progress with different therapies that have been approved. And then this oral, so one of the backbone therapies for patients who do evolve to a higher grade MDS are something called hypomethylators. And in the United States, we have two of them. One is called azacitidine. And the other, some people know that as Vidasa, and that you can get as an injection. Usually it's a couple injections on the same day, or decitabine or Dacogen. And up to this point in time, both of those medicines have been, and then decitabine is infusional. So like you said, oral decitabine has been approved, and it's very recently approved this summer. My experience has been in the clinical trial arena where patients were getting it. So it's an oral tablet, and people tolerate it pretty well. When they did the clinical trial, they found the bioequivalency, or does the oral medicine equal what you can get as an injection or an infusion, and it's very close. So the side effects of it have been blood counts that lower as you are on the medicine, and then they recover once the drug is held. So people tolerate it pretty well. It doesn't make your hair fall out. It doesn't really cause a lot of GI distress, either diarrhea or constipation. So that's my experience. I don't know if anyone else on the call has any.
Jean, I've had 21 cycles of IV decitabine.
Okay.
I'm very much interested in moving to the oral. Of course, the concern would be that it's not as effective, which I've had great success with the IV. It's not as effective. And so I'm just wondering, would that trial have tested if you went to the oral and perhaps there was a difference in your reaction or how well it's treating? Could you go back to the IV?
So what I remember about the design of the trial was people got both oral and IV, right? Because they wanted to ensure that was one comparable to the other. Clinical trials have rules, right? And so they have to follow the sequence. And so people got IV and then they switched to oral. If they went back to the IV, I believe that they were taken off study, which doesn't mean that they were stopped, but they weren't followed on trial anymore. So the answer is, within the trial, it was given one way, but if people were on the oral and they had poor control of their disease, the patients could come off and then go back on the intravenous. Yeah.
Thank you. Thanks, Jane.
Yeah.
The next question comes from Ellen. And Ellen wants to know, is anyone taking Reblozyl? It has extended her need for transfusions by 3 weeks. However, her quality of life is very poor.
Well, that's a question for the group. Is anyone else taking that medicine?
Jean, I just know personally, I've had a few calls from MDS patients on Reblozyl, and the biggest adverse event was just a lot of fatigue in the very beginning. So I don't know, other than that, that's what's been reported to me. Although transfusion independence, has occurred, the quality of life is still not great because of the great fatigue experienced.
Right. Yeah, that's been my perception as well for people taking this. So, again, going back to that discussion point of, talking to your doctor, they really need to know how, with the other name for this medicine is called so luspatercept is another medication that was approved, and it is an injection. It's not but people, can't. They most definitely can have that side effect. So, asking your healthcare provider about this is my fatigue level, and in trying to give them a measure of better, worse, the same, how bad can it get? I don't know if I want to do this anymore. And really kind of sorting it out is going to be, but that's a pretty recent, I think it was December or so almost a year for luspatercept to be, but fatigue is pretty common. And, like headaches, bone pain, that kind of stuff goes along with it for some, but not for all. I'm sorry, I don't really have much to say other than that. But again, just go back to your doctor and say, hey, I'm on this drug. I don't, if I've been on it this long, yes, it's been extending the transfusion time, but I don't know if I want that quality of life imbalance. So, and I'm kind of reading through here, and Phil said there's an oral azacitidine. Yeah, so there is the oral formulation for azacitidine is also available. However, I will tell you that its approval was done for acute myeloid leukemia for patients who had gotten induction therapy and were in a remission with their consolidation. So there are further trials in azacitidine going on, nothing approved for MDS. Unlike the oral decitabine study, there was not a bioequivalency that went along with it. Patients just got the oral AZA or a placebo. So to be able to tell. So the big concern in the hematology world is that where is it? How equivalent is it, right? And I think probably the biggest win for patients who have MDS is if we could get to a place where our therapies were oral, so much better, right? So you don't have to go to the clinic like Dave goes for his decitabine, probably, 5 days out of every 4 to 6 weeks. So to make that oral, but that is being tested and under investigation. So you are correct, Phil. You are correct.
Thank you, Jean. There is a question from Ted, a caregiver. Any chance that the drug Revlimid will become generic?
So let's see. How well do I know patent laws? So Revlimid is a drug called lenalidomide, and lenalidomide is currently is a proprietary drug by a company called Celgene. And I believe in the United States, drugs like that have maybe 10 years to their life cycle before they can go generic. Now, it also has a number of other indications. Now that, I don't know if there's anybody in patent law in the group. I don't know where that falls. So I believe that Revlimid was approved for low-risk MDS. Alan List was one of the primary investigators, and that was done in the early 2005 or so. So here we are in 2020, so that's 15 years. That's as far as I know. Drugs do come off patent, right? And then they lose their, azacitidine used to only be known as Vidasa. Its bioequivalent form is something called azacitidine, right? So it's off of patent. That drug came to the market in 2004. So, yeah. let's see.
I know that I got another message. It was just regarding ordering, whether it's our 100 Questions and Answers book or our Building Blocks of Hope for Patients and Caregivers. Just to answer that, yes, the phone number on the MDS Foundation website is correct. You can dial the 1-800-637-0839 number, extension 208. And Dee from our office will mail you out the materials that you requested. Most of us are working remotely from home, but working as busy as ever from home. So even though I'm not in the office, I retrieve my messages on my phone and try to call you back as soon as possible. So I just want to encourage you, if you need us for anything at all, we're still operational and happy to help.
Yeah, I'm just reading some of the group chats, and someone said that their mom's doctor in Florida, she's getting Vidasa or azacitidine injections, 2 of them a day for 5 days every 4 weeks. So that's pretty common. Like I said, the injection, often you have to get more than one. There's only so much fluid they can put in a syringe. And so depending on the size of the person, then it depends on how many injections. It can be given intravenous. They're the same. And it says the doctor took her off because the white blood cells were so low. So now she gets transfusions. So, part of me would, it is an expected side effect. If you read some of the resources that the MDS Foundation has, it is a common side effect for your blood counts to go low and for the counts to get lower before they get better, right? So there's an analogy, the malignant clone or the problem with the MDS is what's creating all your blood cells. And so as that begins to get removed, oftentimes the blood counts go down. And so, I think it's always a good idea if you're a little uncomfortable, kind of don't understand why the doctor's doing that. Yes, ask them. But then I would say if you're in Florida, there's a number of really good centers and centers of excellences that your mom could go to for a second opinion. And I would highly encourage you to see someone who is an expert in MDS. It's hard to be an oncologist and there's a lot to learn. And when you get treated for a rare disorder, you want to go where somebody's used to treating people with rare disorders. So perhaps getting a second opinion might be something that could be very useful to you. So another question was, is it as effective as oral? Is IV and we don't know yet. So I just know it's not approved. The other thing is, insurance companies, all of us hate insurance companies, but, they are the gatekeepers. So if your doctor wanted to try it, I would say more than likely the insurance companies could say, no way, it is not approved. It's approved in AML. That's where we cover if you want to, otherwise it's out of pocket and nobody can afford that. So somebody, Maureen, said that she's in a clinical trial at Vanderbilt with oral azacitidine, and she's doing well with minimal side effects. So thanks for sharing that. Great to hear.
Jean, I actually know Maureen, and she has myelofibrosis, the most serious of the myeloproliferative neoplasms.
Mm-hmm. Yeah, kind of the whole sister, if you think of concentric circles, there's MDS and then there's myeloproliferative disorders, and there's some people who are unlucky enough to overlap in 2 of them. So sometimes that happens. So they're very similar, but they're not identical disorders. So Vanderbilt's a great place. How do you determine if centers is a center of excellence? Go to the MDS website. There's a list of them. Sometimes doctors move around, right? We all change jobs and we move places. There's some doctors who have moved different locations, but I think both Audrey and Tracy and the staff at the MDS Foundation are your best, easiest way to find, hey, this is where I live. What's close to me. Trying to scroll down.
If I could add to Amy's question, we don't get that designation easily, a Center of Excellence designation easily. The institution has to be affiliated with an academic teaching hospital, because when you're teaching medicine, you have to be at the forefront of medicine. They have to have recognized morphologic expertise, board-approved clinical trials. The doctor has to be very well published. If their literature is too light, or if not published in very well-respected blood journals, they will not get that designation. So that touches lightly on the extent that we go to in giving that designation.
Yeah. Other questions?
Yeah, I want to encourage everybody. We don't want you to, and Jean always says that, we don't want you to leave without your question answered. So please take this opportunity. And Jean gratefully is extending, I don't know if you noticed, but we've gone over the time allotted. I know Jean would spend we'd have to kick her out. She's always happy and very caring and wanting to answer everybody's questions. But we have another, about 5 minutes.
Someone asked a question on here. Is there a good guide to understand what the first 100 days post-transplant can be like for a caregiver? So there's another organization called BMT Info, Bone Marrow Transplant Info. And they also have a website. And Be the Match is the organization that runs a lot of these matching efforts, and they also have it. So if you go to Be the Match and look up for caregivers, they can give you a good idea for the first 100 days. Because for those of you who aren't aware, the expectation is that if you have a transplant, you have to have a caregiver with you for 100 days, right? And live within a certain distance from the center. Ours was you had to be like 30 to 45 minutes a driving distance away. So that can look different. And depending on where you live in the country, options they look very, very different. Like City of Hope has on-campus housing, MD Anderson, Mayo Clinic, they offer different options. So it looks different.
There is a question from Tiffany, Jean. I don't know if you see it. What are the symptoms of late stage MDS?
So late stage? So let me clarify. So there are two major subgroups of MDS. There's low risk MDS, and then there's high risk MDS. So the folks who fall into the diagnostic category of low risk MDS are people who need help with low blood counts. People who have higher risk MDS are people who yes, need blood counts, but their number of immature blasts in the bone marrow is higher, and they need more therapy than just transfusions or Epogen or Aranesp to stabilize their disease. They need treatment. So it's increasing needs. The symptoms would be increasing needs of transfusions, but other things, if I don't know how familiar you are for someone who are new, one of the things you want to know about your MDS is what kind is it, what type is it. So we had Pat, I believe, talk that she had RARS or refractory anemia with ring sideroblasts. And then you want to know, so what type do you have? And you want to know this IPSS score. So it's called the International Prognostic Scoring System, and it was revised. Dr. Greenberg led the effort with that, and it is being revised again. And every time it gets revised, what we see is that the revisions match the progress in science. So initially it was trying to understand
why one person's MDS was different from the other. Was it gender? Was it age? But they found out that it was really, what are your cytogenetics? So what is the DNA of your MDS? How many blasts or immature cells in the bone marrow did you have? And then how many low blood counts? How many cytopenias? Then with the IPSS-R, we started, delving out and dissecting out those cytogenetic abnormalities even farther, right, to more specific ones. And now we're in the age where patients have their blood looked at, and the molecular markers are further investigated. So they do something called a next generation sequencing panel, or NGS. It's horrifically expensive. We fight with insurance companies to get it covered. It can be anywhere from $3,000 to $5,000. It gives the doctors a lot of information, and some people can have abnormalities within that that show they may not have low blood counts, but they have the abnormality, and so treatment might be needed. So something called a GATA2. GATA2, folks who have that can develop MDS. Many times it's for younger patients, so they may get aggressive treatment and a transplant because they need a new source of their bone marrow. So that's what an IPS score. How important is it to know your IPSS score? I just think it empowers you, like how to understand what your MDS is. And what is the doctor looking at? That's what they're looking at, right? They're going to look at the morphology. They'll talk to the pathologist and get an understanding of what it looks like under the microscope. So what's really going on? But that IPSS score, it further differentiates what type of MDS you have, and then what are the strategies. So it unfortunately is not really a dynamic score. So in general, people are scored when they get initial diagnosis, and people do get rescored, but it was designed to really understand upon presentation, where do you fall? What type of, as you get newly diagnosed, like some of the folks in this group are. So it's information, and I think it empowers you to understand, and it will help you set expectations, right? Because expectations for low risk versus high risk look very different. Somebody said their wife was recently diagnosed with deletion 5q MDS. What can we expect from lifestyle changes? Again, 5q MDS in its purest forms, the majority of patients who have 5q MDS have a lower risk. So again, we're looking at people who need red blood cell transfusion support. Lenalidomide or Revlimid, that drug we talked about, can be a treatment for those people. It's an oral pill. It has been proven to help low-risk patients with 5q minus MDS. So Dan, I would, be asking, is that something in the future? When would you choose to do it? So I would ask that. Newt says sometimes it is sometimes possible to get insurance coverage for unapproved drugs with off-label processes. That is true. I totally agree. There's a little legwork, but there can be processes to do that. So you are right. There is a workaround. Does it work all the time? Does it work a lot of the time? It can work a lot of the time, especially if the diagnosis really is close to, and so you petition with the manufacturer to get approval, and so then you bypass the insurance company and you'll go with the manufacturer of the drug.
Thank you. That's all the time that we have for questions. For those of you who still have questions, please feel free to reach out to me at ahassan@mds-foundation.org. If you missed out or would like to revisit this webinar, be on the lookout for an email that will provide you with the link within 4 to 7 business days. On behalf of the MDS Foundation, thank you for joining us. This concludes today's program.